In this presentation, I'll be talking about the maxillofacial CT search pattern. So these are the elements of a search pattern. Now, maxillofacial CTs tend to get done for a number of reasons, and so the indication really matters in how you tailor your report and which one of these different components you look at first. For instance, if the indication of the study is, you know, neutropenic fever evaluate for sinusitis, you talk about paranasal sinuses first. But if it's about trauma and you've got lots of facial fractures, obviously you want to talk about the facial fractures, and in particular the facial fracture patterns first. And we'll talk about this as we go through each individual search pattern. I've highlighted the orbits and intracranial compartment because these tend to be the two where truly urgent findings that are emergent and can't wait tend to be in either orbits or in the intracranial compartment, the parts that you can see. And these are tend to sometimes be overlooked. For instance, if you have sinusitis, you describe all the sinus disease, you forget to see the subperiosteal abscess in the orbit, or you forget to see the evidence of a subdural abscess in the intracranial compartment. So these, no matter what the indication is, always interrogate these two. Never forget about these two because they happen to be the truly emergent findings tend to a lot of times be in those two parts of the search pattern. So we'll talk about the paranasal sinuses first, and first up will be maxillary sinuses. So these are your paired maxillary sinuses on either side. Now when you're looking at paranasal sinuses, you talk about any mucosal thickening. This particular patient has almost no mucosal thickening, but mucosal thickening would look like soft tissue right here next to the bone. You give sort of a subjective assessment of how much thickening there is. If you see air fluid levels, so you see a line that's perfectly horizontal, you know that there's fluid that's layering. The only times you see perfectly horizontal line or when there's fluid layering on your CTs. Air fluid levels, you tend to mention them. What is exactly their significance of air fluid levels is a bit debatable. Some people say that they're indicative of acute sinusitis, but that's really not true. I mean, that just means you have free flowing, liquid and snot in your sinuses. Doesn't necessarily imply much, but you just mention it basically. You look at the walls of your sinuses all the time. You want to make sure there's no erosive change. This is just as aggressive sinusitis. And then in the setting of chronic sinusitis, a lot of the times the walls tend to become very thickened and sort of increasingly sclerotic and extending to the adjacent bones. And those things, they're osteitis of these walls, and those are indicative of chronic sinusitis. So if you see those thickening of the walls, you can say there's indicative of chronic sinusitis. Now, whenever you talk about the maxillary sinus, you want to talk about osteomeatal complex, and osteomeatal complex is really best seen on the coronal images. And here is a nice shot of your osteomeatal complex. So the components of it would be your maxillary sinus ostium. So here it is. This is the maxillary sinus ostium, connects your maxillary sinus to the nasal cavity. This part here, this gas-containing part here is the infundibulum, and then this gas-containing sort of semicircular part right here, where it's connecting to the nasal cavity, is the hiatus semilunaris. So hiatus semilunaris is infundibulum. Hiatus semilunaris also serves as the opening of like frontal sinus and the anterior ethmoid sinuses as well. So those are the three components of the osteomeatal complex. You basically want to see it nice and aerated like this. And if there's mucosal thickening here, you'll say there's mucosal thickening or mucosal opacification or occlusion of the osteomeatal complex. All right, so then we'll talk about the ethmoid sinuses. So ethmoid sinuses are just these sinuses right here. So they're between your frontal sinuses up here and between your sphenoid sinuses and the sphenoid bone. These two are your sphenoid sinuses. They're a bunch of small cells, and those are the ethmoid sinuses, just similar to what I talked about in the maxillary sinuses. You talk about mucosal thickening, walls, and if there's any air fluid levels within them. And then you talk about the frontal sinuses. So frontal sinuses are these two paired structures. And then frontal recesses are basically the connection between the frontal sinus and the sinonasal cavity. When I'm looking at frontal recesses, I tend to just follow them on axial. So I'm following the axial here, the right frontal sinus. And then whenever I see this ear here, that's always connected, and it comes all the way to the nasal cavity right here. So this area right here is the frontal recess. Now, you can also look at them on your sagittal view. So this is the other side. You can see there's actually a little bit of mucosal thickening right here. This is the frontal recess, frontal sinus. Now going into the nasal cavity, this is your hiatus semilunaris. A little bit of mucosal thickening on this side. Looking at the other side, the frontal recess is nice and patent. Here's the frontal sinus, the connection to the nasal cavity. So you talk about these two. Then you look at your sphenoid sinuses. Obviously, sphenoid sinuses are these two guys. Look at them, same things as everything else. And then the sphenoethmoid recesses are again part of the nasal cavity where the sphenoid sinus drains in right here, and also the posterior ethmoid sinuses drain in. So these are the posterior ethmoids draining in here, and these are the sphenoid sinuses draining here. And this right here is the sphenoethmoidal recess. So you want to mention, whether it's patent, occluded, or not, etc. Now, it's pretty common to get these maxillofacial CTs for pre-surgical planning for sinonasal disease, and there are a few things that you should talk about as far as surgical planning goes to help the surgeons. This article here in the bottom is a nice article. If you want to click on it, just hold Control, and that'll make this navigation go away because the navigation is on top of it. They come up with this mnemonic called CLOSE for cribriform plane, lamina papricia, onodi cells, sphenoid sinus pneumatization, and ethmoidal artery. And if you talk about these things, you're talking about a lot of the good pre-surgical issues that the surgeons like to know. So just going over these very briefly. So the cribriform plane olfactory fossa, the first thing they suggest you talk about. So you basically talk about the morphology of the olfactory fossa, and that's basically just the length of the olfactory fossa. So here's the olfactory fossa of the anterior cranial fossa. The length of it is defined as from this top, from the level of the fovea ethmoidalis. This piece of bone that's horizontal is the fovea ethmoidalis, to the bottom, which is the cribriform plate proper, or lamina cribrosa. This vertical bone here is the lateral lamella. So this length, you measure it. If it's above 7 millimeters, it's Kiros type 3. If it's below 4 millimeters, it's Kiros type 1. And the most common is actually in between those two, which would be Kiros type 2. So you talk about that. Obviously, if there's any pieces of these bones that are missing or dehisced, you talk about that. That predisposes people to CSF leaks and things like that, especially if there's a piece of bone that's missing here, and then there's a little bit of the soft tissue pooching out. That's obviously highly suspicious for a meningocele in the setting of CSF leak. Once you talked about the cribriform plate, you move on to lamina papricia. So here's a lamina papricia or medial orbital wall. Just want to make sure they're intact, because if they're not intact and they're doing an ethmoidectomy, it's possible that they might inadvertently find themselves inside the orbit, and obviously that's not a good approach at all. So you talk about the lamina papricia mainly if it's intact or if it's broken and things like that. Then is onodi cells. So onodi cells are posterior ethmoid sinuses that actually lie above the sphenoid sinuses, and they're relevant because a lot of times the optic nerves tend to be within the onodi cells. Now, this particular case does have an onodi cell right here, though you can best see them on coronal. So you identify your sphenoid sinuses here. This is left sphenoid sinus, right sphenoid sinus, and then if an ethmoid sinus is visible where you see a sphenoid sinus on coronal, you know you have an onodi cell. So here is an onodi cell on the right. This is an anterior ethmoid sinus. That's an onodi cell right here. This particular case, the optic nerve doesn't really pooch out into the onodi cell, so it's not probably not that relevant. But sometimes the optic nerve here, this is the optic nerve right there, it can pooch into the onodi cell, and that predisposes it to injury when they're doing an ethmoidectomy. Um, then you talk about sphenoid sinus pneumatization. So here's your, you find under your sagittal, your sphenoid sinuses, and there's 3 different grades of pneumatization, and they're all related to this sella, basically. There's the conchal pneumatization, where there's a whole lot of bone between the anterior margin of sella and the posterior margin of the sphenoid sinus. So the sphenoid sinus would only come like this much. That's like the under-pneumatized variant, and so that's called conchal. There's the presellar variant, where the pneumatization extends just to the anterior margin of the sella. And then there's this sellar variation, where the pneumatization extends all the way to the posterior edge of the clivus, which is the case we have here. You can see the sphenoid sinus goes all the way to the edge of the clivus. So this is a complete sellar pneumatization. If it's in between the anterior margin and here, I usually just call it incomplete sellar pneumatization, just because it's not quite pre-sellar and it's not quite sellar. So I call it incomplete sellar. Other things to sort of talk about for the sphenoid sinus, obviously, if the internal carotid artery or the optic nerve pushes in too much into the sinus, here they don't. You can see here the internal carotid arteries, they don't really come in. The bone is a nice thick bone on both sides. So it's not much to be worried about. Sometimes the septum can attach on very thin bone of either carotid canal, and that can be relevant. But here, the sphenoid septum, as you can see here, is attached to a very nice thick piece of bone. So again, if they break this septum or something, it's not really going to damage the internal carotid artery. And then, of course, you also talk about the optic nerves if they particularly pooch out into the sphenoid sinuses, but here they don't. There's nice pieces of bone separating them, and they're not like bulging into either sphenoid sinus. If they're bulging into the sphenoid sinus, you can just say the optic nerve bulges into the sphenoid sinus with thin overlying bone or something like that. And then finally, talking about the ethmoidal arteries is very important. So ethmoidal arteries are these branches of the ophthalmic artery, supply a bunch of the paranasal sinuses. And you can always detect them by this triangular shaped notch in the medial aspect of the orbits here. You can see them right here on the left, and here you can see it on the right. These notches are the anterior ethmoidal artery notches. Now, these are considered protected if they're covered by the bone of the anterior cranial fossa. So there's nothing above them, no pneumatized sinuses above them. If they happen to be, if they happened to be ethmoid sinuses that are pneumatized above the anterior ethmoid notches, then that would be called a supraorbital pneumatization of the ethmoidal arteries, and that does predispose them to injury during ethmoidectomy. So you want to mention that basically just if there's supraorbital pneumatization of the ethmoid artery notches. Right. Once I'm done talking about the paranasal sinuses, I'll talk about the nasal bone. So here's the nasal bones on either side. Nasal bone fractures, very common to have, and also commonly, a lot of times they're common to be chronic. So a lot of times we overcall them in the acute setting. Usually, if there's no soft tissue swelling there, I might say there's like angulation of the nasal bone without soft tissue swelling, likely chronic. Or if it's in the setting of trauma, I'd say correlate with sort of direct signs of trauma, because they should be pretty obvious if somebody just got punched in the nose or something for them to be able to tell. And then looking at the nasal septum right here, it tends to be easier for me to look at it on the coronal plane. You want to look for any spurs if it's for, sinonasal disease. Obviously, if you're looking for fracture, you look at it in all planes. But looking for spurs and things like that is much easier on coronal. So spurs are basically little outpouchings of the nasal septum. This particular patient doesn't have any spurs. The nasal septum is pretty much in the midline. But if you had a bony spur, there'll be a piece of bone hanging in right here and kind of occluding here. So you just make a note of them for the surgeons. And then the nasal cavity proper, obviously these are the airways of the nasal cavity proper, and if there's a lot of swelling or sinusal thickening, you say there's a opacification of the nasal cavity as well. A lot of times patients tend to have like nasal polyposis, so there'll be a lot of soft tissue and opacification here. A lot of times you can't see the individual polyps just because they're all bunched together and it just looks like completely opacified, but you mentioned that it's opacified, and these are the sort of things that they can see well enough. You just talk about it a little bit in your report, but the direct visualization of the nasal cavity is pretty easy for ENT. After that, we'll talk about the mastoid sinuses. So the mastoid air cells here, just look at, see if there's any fluid within them, if there's any opacification within them. I always sort of lump middle ear cavity at the same time. If you see any sort of opacification in the middle ear cavity, automastoiditis, that means you sort of, a lot of times these things are connected. Here's the additus ad antrum where the middle ear cavity is connected to the mastoid sinuses. They're sort of connected anyways, but I tend to look at them both at the same time. If you see anything wrong in the mastoid sinuses, always go on your soft tissue. I don't have the soft tissue, and look at your nasopharynx here and make sure there's not a big mass or something here occluding your eustachian tube and resulting in this opacification you see in your mastoid air cell. So that's very important. Next, we'll talk about the soft tissue orbits. When talking about soft tissue orbits, I typically talk about the globes. Now, globes can be pretty reasonably assessed with CT. Um, You want to look at the anterior segment of the globe, which is anterior to the lens, and then the posterior segment or vitreous, which is posterior to the lens. Note that I said anterior segment and not anterior chamber, because anterior chamber and posterior chamber are both located anterior to the lens, and their anatomic structures, gross anatomic structures, and they're both located here. And the posterior chamber is really small, and you really can't tell the distinction between those two on CT. So I just say anterior segment just to be sort of more correct and not confuse anybody with that anatomic distinction. So the things to look for the anterior segment is if they're symmetric or if one side looks more flattened compared to the other. That could be a sign of orbital rupture or globe rupture in the setting of trauma. If there's any abnormal contour of one globe compared to the other one, obviously that's worrisome for globe rupture, and if there's any like hemorrhage or hematoma within this posterior vitreous, etc. Once you're done talking about the globes, I look at the extraocular muscles. And extraocular muscle is actually pretty well seen on the coronal image. Here you can see this is superior rectus, inferior rectus, medial rectus, and lateral rectus. This muscle right here is the superior oblique. It comes in from anterior-posterior. It's pretty and kind of anterior-posterior oriented, and then once you reach the trochlea here, it kind of takes a sharp turn and then becomes more horizontally oriented and attaches to the anterior margin of the globe. Now the inferior oblique muscle, here's the insertion of it on the globe, and then it comes down and it medially attaches to the medial aspect of the orbit. It's a little bit harder to see just because it's a smaller, very small muscle. And it's important to know that these extraocular muscles define two spaces within the orbit. There's the intraconal space, which is bound by these rectus muscles right here. So this is the intraconal space. That's the space that's more dangerous because your optic nerves there, and if you have a big hematoma here, they can cause mass effect and result in orbital problem or optic nerve problems. And then you have this space outside of these sort of rectus muscles, which is the extraconal space, kind of like here. So whenever you have hemorrhage or hematoma inside your orbits, you want to specify whether it's intraconal or extraconal. Another thing to note, be mindful of, whenever you have sinonasal disease, like actual mucosal thickening, always interrogate the fat in the orbit right next to that sinonasal disease. The fat should be pristine with the exception of the muscles, and you know the muscles, so don't mistake this superior oblique muscle as something sinister. But all the other fat should be nice and pristine, and if this fat has anything other than the muscles in it, that's suspicious for a subperiosteal orbital abscess, and those are very urgent things that you want to let people know about because they can enlarge and cause orbital compartment syndrome and potentially damage the optic nerves. Finally, when you're done talking about those, you talk about the lacrimal glands. Lacrimal glands are in sort of the superior lateral aspect of the orbits. They'll be right around here, this extra tissue here. And here they're normal, so there's not much to say about them. But sometimes they can be inflamed in the setting of dacryoadenitis, or they could be involved with things like lymphoma, so they'll be enlarged. And finally, there's the lacrimal sac. So lacrimal sacs will be right here around the medial orbit. Sort of it is this right here is the lacrimal duct region, and then lacrimal duct comes together to the lacrimal sac right around here. Here they're normal, so there's not much to see, and pretty hard to actually detect them. But if they're inflamed, that's dacryocystitis, and then there'll be a rim enhancing structure here, right where the lacrimal sac is supposed to be. Once you're done talking about the soft tissue orbits, you talk about the osseous walls of the orbits. And again, those walls show up pretty nicely on the coronal view. I mean, you have to look at them on both the axial and coronal, because axial for the lamina propria and the lateral orbital wall, I think axial does a very good job of letting you visualize these orbital walls. And then for the orbital roof and especially the orbital floor, the coronals are key to make sure you're not dealing with sort of fractures and things like that. All the fractures that either I have missed or that I've seen other people miss, there's always been mucosal thickening in the adjacent sinuses. So, if there's a subtle lamina propria fracture that missed, you'll see much more obvious the ethmoid sinus next to it is opacified. So if in the setting of trauma, if you see paranasal sinus opacification, always interrogate the adjacent bones, and that happens to be lamina propria, the lamina propria. Obviously, laminar paprisha and orbital floor fractures are pretty common fractures. And whenever you have an orbital floor fracture, you want to look at the infraorbital canal and see if it's involved or not. So if the fracture line goes through the infraorbital canal, that predisposes the patient to infraorbital nerve injury. And then obviously if you have an orbital floor or laminar paprisha fracture gap, interrogate your medial rectus or inferior rectus muscles if they're herniating, if there's thickened, etc., to make sure uh, you don't have higher risk of developing orbital entrapment. Although again, entrapment is really a clinical diagnosis, so you should never say, oh, findings are consistent with entrapment. That's a clinical diagnosis, but you just mention in your report that there's herniation, and the ENTs know that they should interrogate for potential entrapment. Right, next, we'll talk about mandible, temporomandibular joint, and dentition. So mandible, just want to make sure there's no fractures anywhere in that mandible and that the temporomandibular joints are normally located. Temporomandibular joints, I like to look both on the axial to make sure they're located in their sockets, the glenoid fossa, and also on the sagittal. It shows up pretty nicely. Here's the mandibular condyle, and here's the glenoid fossa, and you can see the mandibular condyle nicely within the glenoid fossa in this case. Then you want to look at your dentition. Now the teeth, they actually show up pretty nicely on CT, but you have to window it much with a wider window. So here I'm going to window it nice and wide, like this, and then just a little bit center up. So now you see a lot nice tooth anatomy. So it is very bright enamel here. That's the enamel, very bright, much brighter than bone. Then there's the dentin, similar to sort of bony cortex, and then there's the pulp in the middle, which is sort of soft tissue. Now, dental caries are pretty common when it comes to teeth. Dental caries are going to be basically like little punched out portions of the tooth that's been resorbed by the infection. This particular patient doesn't have any dental caries for me to show you. These dental restorations obviously pretty common and they cause a lot of streak artifact, and they limit your assessment of other structures in the vicinity. Finally, there's a periapical lucency, can happen a lot with the dental disease, and periapical lucency is just a little piece of lucent bone that will be right next to the root of a tooth, typically a tooth that has caries within it or that has dental restoration, so it had previous caries. Another thing to keep in mind is when you're looking in the setting of trauma, always look at these alveolus. So the maxillary alveolus, which is right here, and the mandibular alveolus here on the sagittal plane. Very easy to miss subtle alveolar fractures. Alveolar fracture will be like this little piece of bone right here would be a little bit displaced here. Very subtle fractures, but they're clinically actually pretty important because they extend to the socket for these teeth, and these teeth would actually be loose. And again, usually pretty obvious clinically, like there'll be bleeding around the gum to those fractures, but can be very easy to miss those fractures on imaging. But again, important to catch them because they predispose these tooth from falling out and things like that. Once I'm done looking at those things, I look at the remainder of the bones that didn't fit into any of those categories just to make sure I'm not missing some additional fracture. So the main bones will be like your pterygoid plates. Here are your pterygoid plates, your medial pterygoid plate and lateral pterygoid plate. You look to make sure that they're intact. If there's fractures there, you'd be worried about LeFort type fractures. So, and we'll talk about LeFort type fractures. You want to look for the other components of LeFort fractures. Zygomatic arches, another common area for fractures that does not neatly fit into another category. Here's your zygomatic arches on both sides. So again, make sure that they're intact and they're good. You look at your skull base here, your clivus, central skull base. Make sure that everything's intact. Your mastoid, the petrous portion of your temporal bones, make sure they're intact. And then you look at the portions of the calvarium that you can see here, parts of the calvarium. Typically, they're done as part of a head CT also, so you can look at the calvarium as part of your head CT. But if not, take a look at them on your own CT. And then finally, look at the cervical spine, especially put on some sagittals and look at your cervical spine, especially craniocervical junction, obviously, and any of the cervical spine that you can actually see. So next, we'll talk about some miscellaneous soft tissues that you can see in a maxillofacial CT. So the soft tissues to be very important to take a look at would be this retromaxillary fat right here. This is also part of buccal space, but you can call it retromaxillary fat just because it's behind the maxilla and it's easier to remember, at least for me. So this retromaxillary fat should be nice and clean. If you have sinonasal disease in the maxillary sinus and there's infiltration of this fat, that is a bad sign. Like you gotta make a big deal of that because that could mean that this sinusitis is actually quite aggressive and is extending to this fat. So gotta watch out for this retromaxillary fat. You typically see parotid glands pretty nicely on this maxillofacial CTs. Here's a parotid gland on the left, here's a parotid gland on the right. Again, pretty common to see little nodules and masses. They'll typically be pleomorphic adenomas, but you know, very hard to tell them apart from other tumors sometimes. And then, you look at your submandibular glands, you see parts of them here. So, you can look at those as well. Flora of mouth, again, I'll have a lecture on the next CT search pattern, and so I'll talk about a little bit more about flora of mouth anatomy, but just make sure that there's nothing, no big mass or effacement or anything like that. And then the portions of the pharynx that you can visualize are, of course, very important. Make sure there's no asymmetry or soft tissue, especially if you see, as I already mentioned, if you see a mastoid mucosal thickening or fluid, make sure that there's no effacement of the nasopharynx right here, because that's where the eustachian tube comes in. Don't forget to put your brain windows on and look at the brain, especially looking for hemorrhage. A lot of times these things tend to get done. They say neutropenic fever, evaluate for sinusitis. Sinuses will be clean, but you got to remember these people who are neutropenic, a lot of times it's from chemotherapy, and they're also thrombocytopenic, and not at all that uncommon for them to sometimes have hemorrhage because they'll have like a headache and a fever, and then the headaches because they have a small hemorrhage or a subdural or something. So definitely make sure to look at the brain. If you have sinonasal disease in your sphenoids or in your ethmoids, interrogate these inferior frontal lobes carefully. Obviously, interrogate everybody, just inferior frontal lobes or gyrus recti carefully. If there's any hypodensity here, that could mean there's intracranial extension of that sinusitis and causing, infection of the adjacent brain, and that's very aggressive sign. So you gotta make sure. Sometimes the sinus thickening could be pretty unimpressive, and then there's this sort of hypodensity in the brain, but that implies very aggressive disease that's going through the bone and going to the intracranial compartment. So again, brain very important. The urgent stuff, as I mentioned, tends to be in the brain and the orbits for these maxillofacial CTs. Right, so that's kind of a nice search pattern. It's relatively thorough, and it's kind of got a good structure for structuring how you look at these maxillofacial CTs. Now, I will tell you, if you ever in a situation where you're doing this for trauma, and then you all of a sudden open the case and you can immediately tell there's tons of fractures, it can get overwhelming pretty quick, and that's why I think these fracture patterns are very nice, because they allow you to get all those really complex fractures and then just put them into these little nice categories. And so instead of giving a laundry list of what's broken, this broken, that's not broken, you just say, there's this fracture pattern, and then colon, and then you describe all the fractures that fit into that fracture pattern. And when the fractures are really complex, it'll be a combination of these. And then you realize that once you've described the fractures that belong to these sort of patterns, very little fractures are left over, and then those fractures are left over, you just list them as like a laundry list. So these fracture patterns I actually find very helpful for organizing my report, and so we'll go over these next. So the first fracture pattern that's worth knowing is a naso-orbito-ethmoid fracture pattern. This is nice because the name implies exactly what it is. It involves typically comminuted fractures of the nasal bones, the nasal septum, orbits, medially especially, and then the ethmoids. So when you have those, you can just say the components of naso-orbito-ethmoid fractures are present, colon, and then just list the laundry list of fractures. So things to look for, especially when you're talking about the ethmoid components of the fractures, look to see if any of the ethmoid roofs are disrupted or there's intracranial extension of the fracture. Those can show up nicely on coronal, but also reasonably nicely on sagittal here. You can look at this as sagittal projections. Make sure that there's no fracture gap going to the intracranial compartment. Then another thing that you should talk about when you're dealing with these naso-orbito-ethmoid fractures are the medial candon tendon comminution. So the medial tendon sort of holds the orbits together, and it's a tendon that inserts around the lacrimal sac. So to find where the lacrimal sac is, you'll see here that's the lacrimal ducts right here, these little holes. And when they come to the orbit, this right here is the lacrimal sac, and this little piece of bone here is where those medial tendon is insert. So again, you talk about the level of comminution. If it's like one large fracture fragment here, that's typically good because probably the tendon's intact. But if there's tons of little fracture fragments and tons of comminution here, that's bad. Possibility of the tendon being injured is higher. So that's a good thing to talk about at extra detail about the naso-orbito-ethmoid fractures. The next very common fracture pattern that's good to know about is the zygomaticomaxillary complex fracture. This fracture, also called a tetrapod fracture because it involves fractures either involving or immediately vicinity of these four sutures. These are the four sutures that hold the zygomatic bone to the rest of the brain. And basically what this fracture implies is dissociation of the zygoma from the remainder of the face. So those sutures are, of course, the zygomaticotemporal suture. Here it is. Here's the zygomaticotemporal suture connecting the zygoma to the squamous portion of the temporal bone. Again, you don't necessarily have to have a fracture exactly at the level of this suture. Anywhere along the zygomatic arch is the same equivalent because it will still dissociate the zygoma from the rest of the temporal bone portion. So any fracture of the zygomatic arch or the zygomaticotemporal suture would count as the first component of it. The zygomaticomaxillary suture, relatively hard to see, but basically where the zygoma meets the maxillary sinus right here. So any fractures or comminution, sort of this lateral aspect of the maxillary sinus where the zygoma reaches, that qualifies as fracture involving or in the immediate vicinity of zygomaticomaxillary suture. Again, doesn't necessarily have to be the suture itself. Any comminuted big time fracture here laterally where the zygoma meets the maxillary sinus counts as that component. And then you have I'll talk about the zygomaticosphenoid suture because that's also shown well on the axial. And this is the zygomaticosphenoid suture. This is the zygomatic bone. This is the greater wing of the sphenoid bone. Zygomaticosphenoid suture is right here. These fractures tend to be pretty subtle, so you gotta keep a close eye on both sides. There'll be just a little bit of offset typically. Sometimes it's more, but typically they'll be pretty subtle, these ones. And then the zygomaticofrontal sutures are best seen on the coronal projection. So we'll go to coronal. And then here's the zygoma, and here's the zygomatico frontal suture. So the zygomatico frontal suture right here. So you have a fracture or diastasis of this zygomatico frontal suture right here. You can see it, a little bit of the suture right there, that lucent line. And looking side to side for symmetry is going to be pretty helpful, but that's where that fourth component would be. So again, this is pretty nice. You look through these, look for these, and then if they are there, you'll be able to say the components of ZMC fracture are present, colon, and then you put the laundry list of all the sutures that are involved. All right, the last fracture patterns or the LeFort fracture patterns, and there's three different LeForts, LeFort 1, 2, and 3. Now, all the LeFort fractures have in common fractures of the pterygoid plates on that side. So whenever you look at your pterygoid plates, if they're fractured, always look for LeFort patterns of fractures. Now, this article, again, very nice article, and as a reminder, you can hold control. That will make the navigation panel go away, and then you can click on this link. I strongly suggest that you read this article. It goes over how to simplify the classification of these LeFort fractures. Now, LeFort 1, obviously you'll have fractures of the pterygoid plates, but it's basically a horizontal fracture that dissociates the maxilla from the rest of the face. And what distinguishes this from the remainder of the fractures in the LeFort category are fractures involving the lateral margin of the nasal fossa. So here's the nasal fossa. All these LeFort 1 fractures would involve components horizontally going through the nasal fossa. There'll be horizontal fractures, so then they extend along here. They'll involve the maxillary sinus horizontally, and then they exit out. So these are the LeFort 1 fractures. They kind of make your maxilla movable with respect to the rest of your face. Now, LeFort 2 fracture, again, you'll have a fracture of the pterygoid plate, but then it starts around the nasofrontal suture, kind of right here. This is the nasofrontal suture, this is the nasal bones. You can see this little suture right here, nicely seen on the coronal projection. Starts around the nasofrontal suture, kind of goes back and involves the medial orbital wall right here. And then as it's coming down, it involves this orbital rim. And this inferior orbital rim right here, this fracture right around here where the inferior rim of the orbit is, that's what distinguishes LeFort 2 from all the other LeFort fractures. LeFort 2 would be the only one that would have this. And again, this is based on this article nicely talking about what distinguishes the different LeFort patterns. So then it goes down through the inferior orbital limb and then goes through the maxillary sinus. So that's a LeFort 2 fracture. Again, remember to very nicely seen on coronal projection and in particular with involvement of the inferior orbital rim. If the orbital rim inferiorly is intact, you do not have a LeFort 2 fracture. Finally, we have the LeFort 3 fracture, again having pterygoid plate fractures. Then these fractures also start sort of around the nasofrontal suture right here. Then they extend more horizontally through the upper aspects of the orbits, and then they go through the lateral orbital wall and rim. So right here, this part would be fractured. That's a unique feature of LeFort 3. Again, LeFort 2 was the inferior orbital rim. LeFort 3 is the lateral orbital wall and rim. And then once they've fractured through here, then they go on and then they involve the zygomatic arch. So again, they'll go on and then they involve the zygomatic arch right here. So the involvement of the zygomatic arch and the lateral orbital wall and rim are the unique features for LeFort 3. So if you have these fracture patterns, you know you can have LeFort 3. Again, if you look and your lateral orbital wall is intact and your zygomatic arch is intact, you don't have a LeFort 3. So that's how you can tell LeFort 3.